Good afternoon, and welcome to the Wilmot Cancer Institute Community Conversations on Cancer series, sponsored by the Office of Community Outreach and Engagement and its Cancer Community Action Council. I'm Dr. Candice Lucas, and it is my pleasure to introduce today's topic and our amazing speakers. But first, I must note that we will not have live ASL interpretation available for this session. Although we scheduled interpreters in advance, there were last-minute conflicts that prevented them from being available for this session. And unfortunately, we were unable to identify alternates with such short notice. However, this presentation is being recorded and will be transcribed for future viewing. Our deepest apologies for this inconvenience. Community Conversations on Cancer is an educational series designed to inform, educate, and disseminate best practices in research, clinical care, and community engagement to faculty, clinicians, researchers, and community members. Through this format, evidence-based perspectives on the continuum of cancer care and research will be highlighted along with the lived experience of our community partners and experts. Topics will address the social determinants, improving healthcare delivery, reducing health disparities, and increasing research participation from underrepresented populations in order to decrease the impact of cancer across our 27 county catchment area. This month's discussion is entitled, "It's About Control, the True Story of Tobacco in Our Region," and it will outline what we know about tobacco, the work WCI has been doing in this field, and how we as a community can work together to decrease incidence of cancer caused by tobacco products and smoking. This live event has been approved for 1 AMA PRA Category 1 credit and 1 contact hour for social workers by UR School of Medicine and Dentistry, accredited by the Accreditation Council for Continuing Medical Education. Throughout our presentation, please feel free to enter questions in the Q&A box located at the bottom of your screen. If you would like a question directed specifically to one of our speakers, please include the speaker's name in the question. Today, we will hear from Dr. Paula Cupertino and Ms. Sarah Welch. Dr. Cupertino is a University of Rochester Medical Center professor of Public Health Sciences and Oncology and Wilmot Cancer Institute's first Associate Director of Community Outreach, Engagement, and Disparities. She leads efforts to strengthen and expand Wilmot's research and connections across its 27 county catchment area in upstate New York. She is a social behavioral scientist who has focused her research on health disparities in underserved and minority communities, primarily among Latinos and immigrants. Much of her work has been in tobacco control, improving smoking cessation, and access to cessation treatments using a community-based approach. Joining her is Ms. Sarah Welch. She is the program director for the Southern Tier Tobacco Awareness Coalition, or STAC. This is a New York State Department of Health program that works to promote tobacco-free environments in Chemung, Schuyler, and Steuben counties. As a public health professional with over 8 years of experience, Ms. Welch's area of focus is tobacco prevention and control with an emphasis on policy, systems, and environmental changes. I will be your facilitator for this event. And with that, I will turn it over to Dr. Cupertino.
Thank you, Candice. Welcome, everyone that's joined us today to talk about an important point, an important issue in our catchment area. And, hopefully my goal by the end of today is to highlight the problem that we have and bring your awareness to, and then also talk about how Wilmot, as its entire enterprise, it's addressing the problem. So let me share my screen. Thank you again, Candice, for the very nice introduction today. So, the work that I'm going to describe here, it relies on a team that Wilmot facilitate and gave me the honor to bring it together about 2 years ago. And one of the goals of the community outreach and engagement to address disparities in the region was to understand what is the problem and how are we going to address this problem with community partnership. So just as a foundation here, Wilmot has made the commitment and a decision to focus on the 27 county in the catchment area. The 27 counties identified was, they were identified because of the population that Wilmot serve and also the participation in clinical trials. Those are the counties. And to have a presence, Wilmot has care locations throughout the region, a strong and steady partnership with Bassett Health locations, and we are in the process of establishing community outreach and engagement offices to make sure that Wilmot research, clinical care, education, and dissemination of programs are available throughout the 27 counties. So I mentioned that I would highlight a problem that we have here in these 27 counties and look for partnership and insights on how can we together address this issue. One of them is that the age-adjusted incidence, the number of cancer in 100,000 and the mortality has remained higher in our catchment area compared to the state in the country. And we move into the question, why? So we know one of the reasons why is that 9 of the 10 most common cancers are elevated in our region. So it doesn't mean that the other cancers don't have an impact on the cancer incidence and mortality, but these are the ones that very likely are driving these disparities between our catchment area and the country and the state. So looking at the lung cancer, after we identify lung cancer is the second highest cancer incidence in our region. So when we go and look at the cancer incidence, we find what we were expecting. In our region, there are disparities. Residents in the rural area and from racial and ethnic backgrounds are experiencing a disproportional burden in lung cancer here, for example, and contributing to the disparities that we saw in the overall incidence and mortality. So we know that if we're going to change the overall incidence and mortality in the next 5-10 years, we need to address and implement models that go beyond one size fits all. We need to pay particularly attention on how we're going to implement our efforts, our research, our education and partnerships in rural areas and in diverse communities. Why lung cancer is so high in the catchment area? This is why is lung cancer and cancer incidence so high? Because there has been a trend on lung cancer and these disparities over time. So we know that the problem has remained in our area over time. A driver of high lung cancer and the high incidence that I showed you early on is there is one main risk factor. It is smoking. And here again, replicated and showing the relationship with lung cancer. It's the relationship, the correlation between smoking and lung cancer is extremely high. So we know if we want to address lung cancer and that ultimately is going to address overall cancer incidence, we must pay attention to the smoking rate and understand where do we need to go to have even a greater impact. As you see here, rural in the Black and Latino community. Here, it's what's happening locally in Rochester. So compared to the state in the country, we have a local problem that we cannot continue to ignore or to implement programs that are not going to address this, what is happening here in Rochester. To give you an example, this is the 2016 data for smoking rate in the country. So let's start with Latinos. The overall smoking rate in the country, it's quite low, about 10%, and there is a significant disparities by gender. But when we look at Latinos in Rochester, we see that there is a disparities. There is something that needs to be done or is happening in the catchment area, that Latinos here have a much higher rate of smoking compared to the country. And one of the reasons it could be because the Puerto Ricans have the highest rate of smoking. And we know that our catchment area in Rochester, there is a high concentration of Caribbeans and Puerto Ricans. Talking about Puerto Ricans, while we see these disparities between by gender, male and female, among Puerto Ricans, we don't see that. And women and men smoke at similar high rates. Let's look what happened in the Black community locally. Smoking rate in the Black community in our area is extremely high. There is a disparities on what is happening in the country and in our region. However, when we look at white, we do not see a disparities. You know, we're pretty close in what is happening at the country. So that leaves us with a question: what are we going to do? What we can do to address the fact that smoking rates among Black and Latinos in our region, it is close to unacceptable. Well, luckily, the community outreach and engagement has facilitated in the integration of the community participation, not only in the education that happens in this forum, but also with action steps. So together, we have, in partnership with communities, convened the Cancer Community Action Council, and they are engaged in action and initiatives with Wilmot researchers and leadership to address the problems that I just highlight. In 2021, in a retreat and towards October, based on the data that I just shared with you, the CCAC, the Cancer Community Action Council, voted on making a priority in 2022 to address lung cancer screening and tobacco control and cessation. So we count, the CCAC has a representation of approximately 46 organizations. 23 counties have attended and participated in the CCAC, and we know it's also a diverse membership. So we know that together, you know, by looking at this issue, and here we are looking for additional partners that could join us, the CCAC, in making lung cancer and addressing smoking a priority. I'm pleased to share that Wilmot, I have joined Wilmot 2 years ago, a little bit more than 2 years ago, but I joined as a researcher that studies smoking cessation in specific communities, why they smoke, and how to help them quit. I joined a team that has more than 2 decades implementing research in the catchment area and contributing locally and nationally and internationally on answering the disparities that we see in access or in smoking cessation outcomes. And this team prioritize the integration of community and also the impact of the community as they design their study. Dr. McIntosh and OSEP have had an important impact with policies by participating in the state tobacco control initiatives. We're pleased to announce that in the past year, we have Wilmot has supported the recruitment of Dr. Patricia Rivera, which has extensive expertise in implementing lung cancer screening registry, not only clinically, but in research. Her research, it focused on addressing disparities. We also super excited that Dr. Karen Wilson joined us, what allows us to even increase our community-based research to the pediatric population. Here is an example of another tool that Wilmot relies to have an impact where the need is the greatest. Wilmot has invested in the development of Canvas, a geomapping tool that allows us to get to the granular level to understand, and here it is. We have several regions in the 27 counties with a smoking rate close to 40%. I told you that one size doesn't fit all, and this guides us to go to these regions and implement our interventions, implement our research to understand why and how we can reduce smoking rates. Here now, I'm moving to the dissemination and the efforts that Wilmot has been doing in the past years, decade, to address lung cancer and smoking cessation. One question for you. In the last 12 months, did your doctor or nurse practitioner ask for or recommended a CT scan to screen or look for lung cancer? You're probably asking myself, I don't know is this important for me? Have you been asked? Well, the reasons for this question is that research in industry and nationally designated cancer center, including Wilmot, has contributed to the development of a low-dose CT scan to identify lung cancer at earlier stage. This has happened recently, so we know that we need to bring this information to the community, and also know that we now have a tool to identify lung cancer early stage, as we do for other cancers, colorectal, and mammography, and cervical. Now, here's the answer. If you meet this criteria, you should get your low-dose CT screen, lung cancer screening, as soon as possible. You should talk with your doctor or practitioner if you are between 50 and 80 years old. If you're currently smoke cigarettes or quit smoking within the past 15 years. And if you have a smoking history of at least 20 pack years. Well, you're probably asking, where should I go? Wow, I think I qualify. Definitely talk with your doctor first. You also can access URMC lung cancer screening program, and you're going to get to this screen, to this page in which you can make an appointment. When you make an appointment, you're going to be contacted by a patient navigator, which will begin walking you through the steps to complete your low dose cancer screening. Start out with a discussion with a specialty in the critical, in the pulmonary division or other divisions on should you get screened, and from there you get scheduled for the screen and come back to get your results. If your results, it's positive, hopefully not. Well, and you're a smoker, let's quit smoking. If you're not, if your result is negative, your lungs are clean, You need to come back next year. This screening needs to happen every year, like lung cancer, and it is time to quit smoking. Quitting smoking reduce your likelihood, your probability of lung cancer by 38%. Well, where should you go to get access to smoking cessation? So the Center for Community Health Prevention has a state-of-the-art and extensive expertise treating smokers in this region for more than a decade. They provide a high level of engagement in person, in group sessions, with there is substantial evidence that it works. You need to contact, you must enroll to participate in the group sessions. Another way for you to access smoking cessation support is through Wilmot Quit Smoking Program, which is delivered through text message. And your medication, nicotine replacement therapy, is delivered free of cost at your house. It's a program that's available in English and Spanish. Wilmot also count with a program with extensive expertise in help cancer patients in treatment or not to quit smoking. We can't forget that the New York State has a robust quit line that offers an opportunity to talk right now. So right now, every time that you meet a smoker, let's call together and you're gonna get an answer and begin the process. They offer patch and many other tools, including a smoking cessation program via text message. This is what I had to share with you today. Looking forward to continue this conversation. Thank you.
Thank you so much, Dr. Cupertino. That was a wonderful presentation. I'd now like to introduce Ms. Welch.
Good morning, everyone. Thank you for having me. I do see some familiar names in the participant list, so I'm really excited to see that. I'm going to share my screen. All right, you should just see my slides. So again, thank you for having me. My name is Sarah. I'm with the Southern Tier Tobacco Awareness Coalition. We are a grant program that operates out of the Chemung County Health Department, but we cover Schuyler, Chemung, and Steuben counties. So in New York State, annual healthcare costs directly caused by smoking are estimated to be $9.7 billion. A tax burden of $937 approximately for each household every year. Significant progress in tobacco control and prevention has contributed to declines in tobacco over the years. However, as the prevalence of smoking declines overall, there are still significant disparities, as Paula was speaking about. Not all populations are equally protected, and as a result, certain subpopulations bear a burden of higher disease and death outcomes as a result of tobacco use, as well as exposure to secondhand smoke. Certain racial and ethnic communities, low-income communities, LGBTQ communities, all experience higher concentration and exposure to tobacco retail advertising, live in places of higher concentration of retailers that sell tobacco products, and have a higher prevalence of smoking overall. Tobacco industry documents reveal that disparities at the point of sale are no coincidence. In fact, the tobacco industry strategically markets their deadly products in communities with limited resources, lower incomes, and less education. As tobacco control program continues to advance, we continue to focus our efforts on reducing the health inequities related to tobacco. So the tobacco control program began, oops, I didn't mean to do that. Sorry. You can't tell, this is my first time presenting via Zoom. So the tobacco control program began in January 2000. So we've been around for about 22 years, and it is built on a foundation of evidence-based strategies and best practices from the Centers of Disease Control and Prevention, the CDC. The tobacco control program is a network of statewide and local contractors who promote policy change through strategies that alter social norms in communities. So trying to make tobacco use less desirable, less acceptable, and less accessible. Over the years, tobacco control program has helped implement a comprehensive clean indoor air law for New York State, has helped maintain community support for the higher tobacco taxes, which encourage people to quit smoking and stay quit. They've increased access to effective cessation services, and they've developed a strong youth action program. To combat the deadly impact of smoking in New York State, the CDC does recommend $203 million of an annual investment in the tobacco control program, but unfortunately the state's investment has continued to remain at only $39 million. But we do what we can with those dollars. As you can see, there is a network of statewide contractors working to combat the tobacco use epidemic. Health Systems for Tobacco-Free New York is a program, the New York State Smokers Quit Line, Health Communications. We utilize surveillance, evaluation, and research. And then what I'll end speaking about is the program I'm with, which is Advancing Tobacco-Free Communities. So the Health Systems for Tobacco-Free New York is a program that assists medical and behavioral health care systems in integrating evidence-based tobacco dependence treatment into care practices and provider capacity in an effort to assist patients directly when they visit a healthcare facility through education, focused counseling, and getting them access to the FDA-approved cessation medications. Related to assisting in cessation is the widely known New York State Smokers Quit Line that offers great resources for those who are exploring quitting using tobacco. It now does include helping people that are trying to quit using vape products or e-cigarettes. And it has the free confidential quit coaching, and it will also provide access to free nicotine replacement medications. So you may have seen ads for a tobacco control program. They place ads on video streaming services, services like Pandora, billboards, all across the state trying to reach communities. They're targeted to populations with the high smoking rates that I mentioned before as well. And then we also conduct our own statewide surveillance, evaluation, and research. I know my program with Advancing Tobacco-Free Communities, we are responsible for conducting research each year and making sure that it's approved by the state, and that contributes to statewide data. So the program that I'm specifically involved with and have been with for the last 9 years is the Advancing Tobacco-Free Communities Grant. This program does cover the state as a whole, all the way from North Country down to New York City, the Western region as well. Every county should have a representative for Advancing Tobacco-Free Communities. What we work on is community norming and environmental-based change. So expanding beyond just one-on-one cessation services to changing the environment in which people live, so that making the decision to be tobacco-free is an easier decision. So we work to reduce the negative impact of tobacco marketing on youth and adults in the retail environment. So at the point of sale where tobacco products are purchased, you think about the power wall as you go to check out of any convenience store. There is a power wall of tobacco products, and that impacts the likelihood of kids picking up smoking, and it also impacts someone's quit attempts. We increase the availability of tobacco-free and now vape-free outdoor environments and public spaces where people live, work, and play in New York State. we increase the availability of smoke-free multi-unit housing, focusing on income-based housing and public housing. And we encourage the adoption of an R rating for the MPAA, supporting smoke-free movies and internet policies. The more smoking kids see, the more likely they are to pick up the habit. So environmental change, policy-based change that affects whole systems and whole communities really stems from community involvement. As a state-funded program, we cannot go directly to lawmakers and these gatekeepers and stakeholders and say, we want to reduce the impact of the tobacco retailers in our community. So we want to only have one retailer. We can't be lobbying because we are state funded. So we work from a community-based perspective to foster environments that support policies and interventions to reinforce a tobacco-free norm. So in order to get a community that is supportive of policy and that may approach their local lawmakers for some of the policy-based changes I mentioned, we engage in community education, advocacy with organizational decision makers. So that's business owners, multi-unit housing, public health authorities, public housing, excuse me. We work with government policymakers and do regular education with our local legislators, as well as community mobilization. So partners and community members participating in all of those activities with us. So we use a coordinated set of evidence-based strategies to build all this support for tobacco control policies. We also have a youth component, and through this civic engagement, the youth program joins us on all of our initiatives, as I mentioned, and they are 13 to 18 years old. And we go into schools, we go into community centers, and we directly educate the community that this issue affects the most. With the average age of a new smoker of 13 in New York State, we engage youth in this issue because it directly impacts them. So what does community education, community mobilization, advocacy with organizational decision makers, government policy major education, what does that really look like in our communities? So what is advancing tobacco-free communities doing on a daily basis? So this is a picture from our legislative day every year. We go to Albany and we educate our lawmakers. We're joined by partners and we're joined by Reality Check Youth. And we educate on all initiatives to build that sustainability piece and remind them what our program can offer and what we do for communities. So these are the local lawmakers in the Southern Tier and Reality Check Youth and ATFC program coordinators. That's Advancing Tobacco-Free Communities acronym. This is the group of contractors across New York State. So clearly this is, shows how well represented across the state we are. These are, my peers that are, from doing this work in the New York City boroughs, all the way up to the North Country. We work with local legislators. This is a county legislator with Reality Check Youth, and he came to a Reality Check Youth program meeting and talked about the importance of engagement with lawmakers and speaking to them about policy change, and he informed the youth of what they really are capable of and the impact that they can have. We also partner with other tobacco control programs across the United States. Each year we go to Richmond, Virginia, which is a big tobacco headquarters, and we demonstrate outside of the annual shareholders meeting and educate them on the impact of tobacco marketing on youth. So this is a local youth educating that 13 is the average age of a new smoker. So this is an example of community-based education. We do murals, We participate in street painting festivals. We do cigarette butt cleanups. We also clean up other litter as well. But this last Earth Day, we did a cigarette butt cleanup, the first one in 2 years. And by going out into the community, collecting tobacco litter, you can use those resources in creative ways to educate lawmakers on the need for policy change. So Tobacco-Free City of Corning was a project that we did a few years ago. And by collecting litter in the playground, we can use that litter as a display to demonstrate the need for a policy change to make that park tobacco-free. A creative way that we did this was flagging the litter as we picked it up. So then you can see all the orange flags where litter was collected. Another creative way to demonstrate the tobacco use issue in your area is donning a hazmat suit. Because when we are talking about cigarettes, we are talking about thousands of chemicals and we are talking about carcinogens. So that kind of raises the media attention, gets it more likely that we will garner earned media or get that article in the newspaper and contribute to that social norming that tobacco use is harmful. So during one season of cleanups, we collected all of this tobacco litter, and we decided, instead of keeping it in this, and disposing of it, let's get creative. So we partnered with a local arts organization, a community arts center, and we created art displays with the cigarette butts. So the youth came up with such displays as this. And so this is getting, creative, making, we're competing with a lot of different public health priorities and community priorities as a whole. So how do we bring tobacco back into the forefront and make it an issue that people will care about? So these were art displays that were created, entirely of cigarette butts and vape product waste. This is the grass is greener where you don't throw your cigarette butts. And so we invite lawmakers to these, displays and these activities always so that they can see firsthand what's happening in their communities. We hold community events, partnering with local organizations to find bigger spaces than what we have, to find speakers, and we invite lawmakers and those gatekeepers and decision makers to the table to talk about the issues. This is a STAC coalition partner and the mayor of the city of Elmira with a tobacco power wall behind them. And then this was a activity, prioritizing activity for communities. So we had people have their own dots with priorities going from highest priority pink to lowest priority yellow. And they went around the room and we had lawmakers there. We had, local healthcare systems, partners from all levels, community members, and we could see physical evidence of what are they more likely to support, which policy areas are our communities leaning towards, and what are they most likely to demonstrate support for if we were to start to advance a project. So all of this work with partners and with lawmakers and our reality check youth does result in policy change. We can see that most recently with the increasing age of the legal purchase age of tobacco to 21 from 18. That started at a county level. That started with community-based change, educating of local lawmakers, county legislators, to enough counties and enough percentage of the state became, a legal purchase age of 21, that it went statewide, and the statewide senators and assemblymen were more likely to support a policy. So on a local level, cigarette butt cleanups can help educate a community the importance of going tobacco-free. So we have small and large municipalities going tobacco-free every year across the state. Now it is including vaping, as well as marijuana. We do provide policy development support for those substances. And if a municipality or a business goes tobacco-free grounds, we do provide free signage. So those are just examples of that environmental change, stemming from community-based work. So I mentioned that there is a Advancing Tobacco-Free Communities program across the state. I may not have captured all of the contacts for those that are on the call, but here is a group of them. If your region or your county is not in this list, you can go to the tobaccofreenys.org link, and you will be able to access your representative for your county. Many of these contacts have their own community coalitions that you can get involved with. We are always, looking for partners to come on board. So I encourage you to reach out and see how you can get involved. Because of those lobbying restrictions, it really helps directly impact the likelihood of policy change, public health policy change in your area. So I want to thank you for having me on. I guess we'll turn to the next step of the Q&A.
Thank you so much, Sarah. And Paula, we'll have you turn your camera back on and come back. This was truly a wonderful presentation, and the two of you gave so much fantastic information. Paula just outlining the data and what tobacco use looks like across our region and sharing the programs that are available. And Sarah, thank you so much for talking about how you can mobilize community to be involved in this work. So we've had some questions coming in that I would love to get to, but the first one I'll just ask, because you both talked about the disparities that exist across the region. And Paula, you had a graph that was just so striking of the use of the Black population. Can you talk a little bit about what you think is causing such a large disparity for the African-American community specifically that's happening in our region that's different from the rest of the country?
Oh, I have been here for a while, but I think, in terms of the Wilmot, we haven't really developed research projects or that to understand why. We know, addiction, the Black community has a harder time to quit compared to other groups, despite that they are light smokers. They have higher utilization of menthol, and menthol is also correlated with having a harder time to quit. So there are many indicators, but those indicators are happening across the country, right? But so we don't, at this point, we don't have a dedicated, again, one size doesn't fit all, that just look into that problem. And this is why I'm bringing that out here. But we need to do a better job. I don't know, Sarah, how much of your efforts have been tailored and engage the community with that goal to go out there and focus in the Black community. But in terms of Wilmot, and I think this is where we are now.
Thank you. Sarah, did you have anything to add to that?
Yeah, so the New York State Control Program might not have, certain programs for those communities. So we partner with the Center for Black Health and Equity is a great program, the LGBTQ Cancer Networks. So we partner with them on their events. And institute their programs on a New York State level. So this coming Sunday, May 15th, is No Menthol Sunday. And so on a local level across New York State, we are participating in the Center for Black Health and Equity sponsored No Menthol Sunday activities. So we were able to receive toolkits that contain a variety of materials that we can then share on a local level, so that that program that's out of Michigan is having a local reach in New York State. So we really turn to national partners for those focused efforts.
Great. Thank you. Thank you so much. So we have a question here. In general, do you find that the work or attempts to reform tobacco policy and introduce new restrictions are more effective than trying to appeal to individuals? I imagine it can be more difficult to change behaviors of individuals given the reaction. I was told not to do it, so now I want to do it more. And there was a follow-up comment to that about, also people might love smoking and not want to be told not to do it. So can you just speak a little bit to that? Does this seem to be an increasing risk with more advertising?
Great question. And I think, we must understand that nicotine dependence is a chronic disease, and we must approach nicotine dependence as we do for any other chronic disease, right? We don't wait for a diabetic or a hypertension patient to be motivated to quit, to manage their chronic disease. So I think that's the model that we need to move forward based on our experience. When we cold call or we identify a registry of smokers, if anybody have a registry of smokers, and our team reach out, it's about 61% of the uptake of the smoking cessation program. So out of 10, 6 that were not thinking about quitting, they say yes. So I think there is, and we know smokers, to get to a quitting, they try 7 to 10 times. And what happened when we are able to engage them, even the ones that did not quit, have a sense of gratitude. I have never had anybody working with me to quit smoking. Thank you so much. So I think we need to move to treat nicotine dependence as we treat any other chronic disease, and trust, right? Sarah and the team here at Wilmot, we know that if we get them in, we know how to motivate, to get them to set a quit date, to begin a treatment, follow up for 6 months, and get to a sustainable cessation, right, Sarah? So I think we need to think how to get them in offer.
That's great, Paula, to know that you have such a good success rate talking to people at the individual level and getting them to change. Sarah, what do you think about from the policy level? How effective is that?
Yeah, so our work aims to reduce the initiation of using cigarettes from the start, so at the base model. So when you're looking at environmental macro level change, you're trying to solve the problem before it becomes a problem. So we're trying to over time reduce that youth initiation rate, and that's where the policies like Tobacco 21, so increasing the legal purchase age, we won't see, the year after that policy was passed, we won't see that dramatic increase of, youth initiation, or we won't see, the statewide smoking prevalence decrease. It's the over time, the years, as we gather the data, we will start to see that reduction in smoking initiation because it's reducing accessibility to the product itself. So what we are experiencing now, when policies pass, like, in New York State, you can no longer redeem a coupon or a discount for your tobacco products. And that is a huge win. And so right now we're hearing that grumbling or the dissatisfied tobacco user that's upset, but over time, it'll be just a social norm. where, people won't know, recall a time where they could use coupons and discounts, but, it's that social norming. And so we're really trying to change that age of an average new smoker. And, it should not be 13 when the purchase age is, 21. And so that takes that socialization component of getting tobacco products from a peer in the high school that's older. It takes that out of the equation. So hopefully over time, we'll see a change in that data.
Thank you. Thank you for that. I'd like to get to this next question from Emily, and it's such a great question because she's talking about secondhand smoke here. Emily is a home care worker, and she's asking, or stating she wishes there was PPE for smoking like there is for COVID, because when you enter someone's home, they have the right to do whatever they want to do in their homes if they're smoking. But as someone coming in to take care of them, you're now exposed to that. So, is there anything being done around secondhand smoke that either of you can speak to?
So it is secondhand smoke in housing is part of the statewide work plan that does mirror recommendations from the CDC, because we recognize that secondhand smoke in the home is probably it's the place that people are most exposed to secondhand smoke. And the communities that are disproportionately impacted in this are the low income, low education communities living in income-based and public housing. So our work plan really focuses on increasing the number of smoke-free housing policies for these residences. Because the fact is that most people don't smoke. You can see that, with the statewide data. And so these communities are disproportionately impacted because all of the market rate, more expensive housing, as soon as that new building opens up, it's already smoke-free. So it's impacting that lung cancer incidences, that Paula was speaking about, because they're disproportionately living in the housing that's not yet smoke-free. So I say go for it, wear the hazmat suit, if you have one, just because we know the harms now of third-hand smoke. There's more and more studies all the time about the impact of third-hand smoke, and that is the smoke that is, left behind in an environment setting, on clothing, on chairs, furniture, walls, etc. So it's the chemicals that cling to those items. So yeah, and I think now after the pandemic, we're becoming increasingly aware in our communities of the impact of shared spaces, and how much protection, wearing a mask can provide you and the people around you. So that was a good question. Thank you.
It was. Thank you, Sarah. And, really thinking about how you change policies moving forward. Paula, is there anything that you can add about, what can be done now?
In terms of policy?
In terms of protecting people for secondhand smoke.
Yeah, I think, we know that implementing restriction on the use of tobacco indoor, it's correlated with quitting. Families, this is the work of Dr. Wilson, looking at secondhand exposure with kids. We know the parents that when they implement restrictions, the next step is quitting. So we know that that's the direction, and this is why we had the clean indoor, right, policies, and which has been effective, right? So I think there's a component to do it, a lot of education, especially in the communities. They're having an issue, like Sarah. So we need to be out there.
Thank you, Paula. I had a question that came directly to me, and I think, Sarah, this is for you. You talked about the power wall at the stores. So what work are you doing to address that power wall and its effect on the youth?
Yeah, I think I was really trying to focus my presentation and not go too deep in each topic area, because this is the largest part of our work plan, is that power wall in the retail setting, because that is where people get these products. That is where the tobacco companies, or big tobacco is, kind of what they've been referred to, spend the most money. And they spend more in the retail setting than the alcohol junk food companies combined, because they can no longer advertise, in many other places. I kind of touched upon the other place that they advertise, which is in the media through product placement. When your favorite actor or actress is, smoking in a film, that's no coincidence. That was written into the script. That brand of cigarettes that they're smoking was, paid for by a tobacco company, and the actor was, so the two primary places that they can, reach the consumer is the retail setting and media. So with the retail setting, we work to reduce their hold in our communities, especially the low socioeconomic status communities that they target disproportionately. And we do that through reducing the amount of retailers in a community. So it's within a municipality, whether it's a village to a county, it's within their power to institute a retail tobacco policy, or they can do it through zoning. And so they can say, we're a small county with only 80,000 residences. We do not need 70 retailers. So we're going to cap this number of retailers to one, to whatever they have determined. They may say, I don't want my, tobacco retailers to be near youth-focused areas. So then that means that a tobacco retailer cannot be within 1,500 feet of a school. Something the state did to kind of, not the power wall, but exterior advertising. So all the, we have the lowest price cigarettes, etc. They can no longer advertise on the exterior of their buildings within 500 feet of a school in New York State. So that's a recent policy, but that doesn't get to the power wall. So there's a lot that people can do in their local community to advocate for better comprehensive public policy.
Excellent. Thank you so much for that.
And Candice, I just, as we're talking about policy, we cannot forget that we're finally making some move to eliminate menthol from cigarettes. Finally, I think United States has banned all flavors, but have kept menthol, which we have data, substantial data. That's the flavor that it's more, is a prefer cigarette in the Black and the Puerto Rican community. And look at this, we haven't been able to ban. So we are moving that direction. We're closer than ever before. And then we're going to see the impact on cessation. Smoking menthol, if you smoke menthol, it's harder to quit. And there are communities that are using menthol disproportionately. Finally, some equity in terms of policy. We're going to do a policy that's going to impact the communities that need the most.
Yeah.
Paula, I'm sorry, Sarah. Paula, that question just sparked a follow-up that said, is there data around the lung cancer rate for menthol versus non-menthol smokers?
So I'm not sure about the lung cancer data. I'm more familiar with the smoking, but I can get back. But we definitely know, the smoking rate, who smoke, and how hard is to help them quit if they smoke menthol.
Okay. Sarah?
Yeah, I was just going to say that it was such great news with that announcement from the federal level, but unfortunately at the federal level, it may take years for that change to happen. But in our local community, we're educating to, create that social norm and, get ready and educate people that might not have crossed their mind that was possible. We're sharing that, but because it may take years, our programs are still encouraging local communities to institute change and support change, because there's right now a question and answer session through the FDA where you can voice your support for the menthol flavor ban. I encourage everyone to do that. I can share that information with Candice and Christina, but to still continue the work in the community level, because after that opportunity for the public comments, they may decide not to make the change because there's nothing in stone yet, you know. So continuing to build that momentum and that social norming is really vital.
Well, Sarah, Paula, I see we're right at the hour. I want to thank you both for, again, this very informative and educational presentation. There were a few more questions that we got that came in that we did not get to, but we'll get those to you and we can answer those and send them out to everyone. We so appreciate you being on the call today. This will be posted, as we said, it's being recorded, it will be posted, and it will have transcription in there. And again, we apologize for not having the ASL interpretation. Thank you to those of you who were able to join us today. We will see you again next month.
Right, thank you.